Thank you, Dr. Rajat. First of all, thanks for giving the opportunity. We had a lot of positive trials, but whatever four trials that I'm going to present are not so positive in terms of their outcome, but very positive to tell us what not to use. So everything is having a meaning in the research, right? So the first is to compare the quality of life in patients randomized to receive high dose once daily thoracic radiotherapy versus standard twice daily. This is the trial. So this is a CalGB 30610 trial, which has randomized 70-gray QD-TRT, was not associated with superior overall survival compared to the 45-gray PID in limited stage setting, small cell lung cancer. Right? Small cell lung cancer, we hardly discuss anything, but this is a standard thing. They have used total 6 different varieties of quality of life questionnaires, and they assessed at baseline 3, 5, 7, 12, 26, and 52 weeks. That's when you expect the short-term, mid-term, and long-term complications to happen. So once the assessment is done, they try to analyze the results. 417 patients consented to participate, but at the end of the study, they had the data for 340 patients only, and remaining for dropouts for various reasons. If you look at the baseline characters, they're well balanced. If you look at the FAT-L total score, it shows that it was significantly less in the QD arm. That means it is not that well tolerated. If you look at the FAT-L physical well-being, social well-being, and the emotional well-being, in all the arms, the QD arm fared inferiorly compared to the other arm. Similarly, functional well-being, the FAT-L score, FAT-G score, and additional concern score also favored the short-term arm. So, what does it mean? It means the FAT-L TOI means worsening. That means less in the QD arm at week 3, greater in the QD arm at week 12. Similarly, the FAT-E also is having changes which are pretty much parallel to each other. Acute esophageal score was in VID arm and was in QD arm at week 12. So that means there are more short-term complications in the PD arm, more long-term in the OD arm. Difficulty in swallowing, parallel to the acute esophageal score as expectedly, no difference. EQ5D, lesser worsening in the QD arm at week 3. Mean worsening of anxiety is less in the QD arm at week 5. So what does it mean? So it means both QD and PAD radiation regimens are well tolerated. So something is superior at week 3, but something is superior at week 12. So in other words, the QD arm once daily has better quality of life in the short term, but worse at week 12. So you need to really individualize whether you want to use OD dose or BD dose. OD dose was perceived to be less inconvenient compared to the BD dose because the acute period is tied over in a better way. So that's the first study. Coming to the second study, we always debate why 2, 4, 6, why not 2 and 3? Very interesting question that was answered. 2 cycles versus 3 cycles of neoadjuvant sintilimab plus platinum doublet chemotherapy in patients with resectable non-small cell lung cancer. It is called NEO-SCORE study. It's a single center 2-arm phase 2 trial. So it's an immunotherapy that favors MPR rate compared to the neoadjuvant setting. So there is a data of using immunotherapy in the neoadjuvant setting. If you look at various trials which have been presented, they use atezolizumab, nivolumab, toripalimab, compared to durvalumab and other things. So all of them showed that both MPR rates and pathological CRs are superior when you add checkpoint inhibitors to the standard chemotherapy. So they also designed in a similar way. Sintilimab 200 mg day 1 along with chemotherapy, 2 cycles versus 3 cycles. Surgery was done, and if the patient received 2 cycles, they were given 2 more cycles. If the patient received 3 cycles, they were given 1 more cycle. And maintenance treatment of sintilimab till the follow-up. This is the study design. If you look at the planned sample size, it is a phase 2 study, mind you. It was 1 or 2 patients, 51 in each arm. They have been stratified as per the PDL1 score. 60 patients were targeted to be recruited, expected dropout rates of around 20%. So at the end of December 3, 2021, DSMB review showed that to terminate the trial because there is no point in doing the trial any further. So let us understand why they terminated the trial. This is a schema, larger schema, how the trial looked. The arms were well balanced. There is no difference. And if you look at 2 versus 3 cycles, no major difference. The p-value is insignificant. The authors felt that it may be narrow cycle difference, but it is not like 2 versus 4, where you expect more responses, as well as small sample size that didn't favor the p-value. But if they dissected deeply, the pathological CR rate is also not very significant. If you look at the regression, the graphs didn't show any difference between 2 cycles and 3 cycles, though 3 cycles expectedly have a slightly more regression because more number of cycles, but it didn't yield into any of these benefits. So if you look at the stage 3A, they are more in the 3 cycle arm compared to the 2 cycle arm. That's probably one of the reasons where they see more regression, right? So the authors concluded that the planned surgery didn't differ much. The side effect profile also didn't differ much. So they told that 3 cycles can be given. That's the only conclusion they could make, right? So that more cycles of neoadjuvant chemotherapy provide higher MPR rates for the patients with resectable, especially for the squamous subset. So that's a very, very small subset, very difficult to draw conclusions based upon this 51 patients data, but that's what the observation nonetheless. So coming to the third study, it was pembrolizumab versus placebo in resectable early stage NSCLC. What is the difference in the subgroup related to this type of surgery, disease burden, and acute chemotherapy? So it's a large meta-analysis. The patients were randomized to pembrolizumab versus placebo, and the dual primary endpoints were DFS in the overall population and DFS in the PD-L1 positive score of more than 50%. The secondary endpoints were DFS in any PD-L1 expression, OS in any PD-L1 expression, and lung cancer specific survival and safety. If you look at the overall population, they are well balanced between pembro and placebo, so as the PD-L1 with TPS more than 50%. There are no major differences, including the EGFR expression, ALK translocation, and whatnot. If you look at the data, at the end of the 18 months, DFS in the overall population, the pembrolizumab arm is much better. 73.4% of the people have disease-free at 18 months compared to 64.3%. If you look at the median overall survival also, it is 53 months versus 42 months. So DFS is definitely superior. For those with PD-L1 more than 50% score, the hazard ratio, the graphs were not separated that widely. But if you look at the median, which was not reached, it appears as if the pembro arm is faring better. If you look at the overall survival, pembro and PFS, pembro and placebo, no difference, and they are paralleling with each other. So there may not be any overall survival benefit. So if you further stratify these things into bilobectomy, lobectomy versus pneumonectomy, nodal status, tumor size, and the received adjuvant therapy versus not received adjuvant therapy. In the adjuvant therapy, the type of platinum, carbo, cis, or carbo and cis based, sometimes whatever is the differences, and type of adjuvant therapy, that is carbopaclitaxel versus carbovinerolibine versus gemcitabine cisplatin versus gemcitabine vinorelbine versus others. So if you look at these subsets also, they are very well balanced. There is no big difference. So if you look at which arm is doing better, pembro appears to be doing slightly better. In some of the cases where the nodal status are high, or when the tumor size is just less than 4 centimeters, and those who didn't receive adjuvant therapy, the pembro is not showing any advantage over the placebo. So these are the subsets probably where you may not consider pembro in these cases. The author concluded that together with overall efficacy and safety findings, these data support the benefit of adjuvant pembrolizumab for stage 1B, that is tumor size more than 4 centimeters. As I told you, the nodal status, they did matter. Following complete resection and if recommended as adjuvant therapy as well. So these are the recommendations. This is the last of 4 abstracts. This is called Skyscraper 2 study. It's a phase 3 randomized double-blind placebo-controlled study of atezolizumab carboplatin etoposide with or without adding tiragolumab in patients who are untreated with extensive stage small cell lung cancer. Mind you, this is the second small cell lung cancer in this ASCO. There is a GIGIT is a novel inhibitory immune checkpoint present on the immune cells in the many cancer cells, including small cell lung cancer. There's a new drug which was developed targeting this, and they want to see if they add this TIGIT novel inhibitory checkpoint inhibitor will add any benefit in terms of overall survival and PFS. If you look at the study design, the tiragolumab 600 mg once in 3 weeks versus placebo when compared to atezolizumab with etoposide platinum. So the maintenance of placebo atezolizumab versus tiragolumab with atezolizumab was given. So the stratification is ECOG status, brain mets, and LDH levels. Co-primary endpoints was overall survival, and secondary endpoints were PFS, duration of response, safety, and efficacy. So this is the study design. If you look at the arms, they are well balanced. There is no major difference between the race, the tobacco use, baseline ECOG status, LDH levels, brain metastasis. If you look at the arms, surprisingly, tiragolumab has fared inferiorly compared to placebo. That means it has actually produced more harm than good. The interim overall survival also, it is showing inferior survival. 13.6 months versus 13.6 months is the median. But if you look at the graphs, the graph of tiragolumab is dipping compared to the placebo. So the PFS OF interim analysis also showed there is no difference. And they tried to subset based upon the preconceived stratification points. That's also showing no advantage of adding tiragolumab. In fact, the placebo arm is doing better. In various subgroups with brain metastasis, this arm is again, there is no difference. So the objective response also, no major difference between tiragolumab and these things, because complete responses are, though appears to be 4% superior, but the stable disease is almost better in the placebo arm. We don't look into the response rates. We always look into the adverse event rates and the overall survivals. If you look at the adverse event profile, so they are also quite balanced, and AEs of specific interest are slightly more in tiragolumab because we have added 2 immunotherapy agents. Right? The serious adverse events are also more there. So they all just concluded that the addition of tiragolumab didn't add any survival advantage. So these are the 4 things: 2 in the small cell lung cancer, 2 in the non-small cell lung cancer. The small cell lung cancer showed that probably once daily is having a slightly better tolerability, though it is having a long-term and mid-term poor quality of life, but it is still feasible to do OD versus BD in terms of fractionation in the radiotherapy. The second in the small cell lung cancer is addition of the TIGIT inhibitor didn't prolong the survival as expected. It is a negative study. These are in the small cell lung cancer. In the non-small cell lung cancer, irrespective of the subset analysis, atezolizumab has prolonged the survival in the patients, especially if the size is more than 4 centimeters. That's the conclusion of the subset analysis of those studies. So this is what it is from my side. And over to the organizers.
Thank you, Dr. Suresh, for a very nice presentation. So what do you think, which of these studies are going to be practice changing from now on or probably in times to come?
So definitely regarding the small cell lung cancer, radiation oncologists are the best people. I'm not a radiation oncologist, but when I went through these studies, it appeared as if you want a short-term comfort, use OD dose. And if you want a long-term comfort, probably use the BD dose. So I didn't see any major difference. It is more of individualization. That's one point. Point number 2 is the new receptors in the small cell lung cancers appear to be elusive because the new receptor also didn't produce any benefit in the phase 3. It failed. So small cell appears to be status quo, no major change. But yes, definitely in the non-small cell, adjuvant atezolizumab may come into the picture. That's what actually is a positive side of the picture that I see in these cases.
Right. I agree. Thank you so much for a very nice presentation. So we are going to discuss more of this in the panel discussion that ensues. So with this.